Good morning, ladies and gentlemen. Thank you so much for having me once again. I really do appreciate it. I'm sorry about the predictions. They have a bad habit of becoming true. But I think the good news about all this is that we're having basically a second major debate on healthcare, and I think that's great. I mean, very frankly, nothing is settled. Yes, the Affordable Care Act is the law of the land, but it's certainly not settled policy in the United States. I'm going to get into that. What I wanted to do for you this morning, talking with Diane, is primarily give you just the raw facts about the provisions of the law. I think that is really critical because there's an awful lot of stuff on both sides of this issue. I mean, both teams are guilty of spreading through the internet a lot of stuff which is nonsense. So I think, the important thing to do is to be very clear about what the facts are. So that is basically what I'm going to give you this morning in this presentation. So let's begin. I don't have any money. I'm a PhD and I've got the fees to prove it. These are the learning objectives. This is to understand and specifically how it impacts doctors, hospitals, and Medicaid, Medicare practice. I hope this will be helpful to you. Yes, this is a big deal. The law is a turning point in healthcare policy. It's not a continuation of anything. I think we ought to get that straight up front. You'll remember the president's promise, no matter how we reform healthcare. If you like your doctor, you'll be able to keep your doctor. If you like your plan, you'll be able to keep your plan. He made this point over and over again. Period, he says. No one will take it away no matter what. I contrast that with the 1965 Medicare statute, Section 1801 of the Social Security Act, which dealt specifically with this issue of your professional independence. It's in the law. It's never been repealed. The law says nothing shall be construed to authorize any federal officer or employee to exercise any supervision or control over the practice of medicine or the manner in which medical services are provided. You ought to laminate that and put that over your fireplace. That is, in fact, the current law under Medicare. My argument this morning is that the current law has not been so much repealed as just ignored, and let me explain why. The Congressional Research Service, the first-rate professionals, a month after the law was passed, the law was signed March 23rd, 2010. The CRS did a pretty extensive evaluation of it. And their judgment on this is that the new law, quote, makes several changes to the Medicare program that have the potential to affect physicians and how they practice medicine in ways both small and large immediately and over time. So that's the truth. The truth is that we have really turned a corner in this area. And I'm going to show you with the muscle and bone and the tissue of this law how that actually takes place. I want to point out one other thing, and that is people talk about the law, but the law itself in this case is a limited guide. Why is that? Because they passed a 2,800-page statute, which basically overhauls literally 1/6 of the American economy. And they couldn't get all the details right. So what they did is, members of the House and Senate, what they did is they transferred enormous, broad, discretionary regulatory authority to the Secretary of HHS primarily, as well as to the IRS and the Department of Treasury to basically fill out all the gaps or all the details. So what you have is you have very, very broad statutory authority, giving the Secretary of HHS the authority to define things like value in healthcare. This kind of thing. What is the quality of care? What are the standards for the quality of care in adjusting fees or the delivery of care? So what I'm saying to you, and I'm saying to you something, frankly, that I consider very unpleasant, but this is not the rule of law as we normally understand it. This is the rule of regulation, and I think you should know that. We have an 8-year implementation schedule. I listen to some of my friends who say, I'm sick of this debate. I wish it would go away. What you think about whether or not we ought to be debating this year, next year, whatever, has nothing to do with anything. Your opinion on this is irrelevant, and my opinion is irrelevant. The law is huge, and it has an 8-year implementation schedule. And the big stuff, the really, really big stuff, starts on January 1st, 2014. I'm talking about the big mandates on individuals, employers, the states, the mandatory Medicaid expansion. All of that is in the future. And at that time, I guarantee you, depending upon what happens in the next couple of years, we're going to be involved in bitter and heavy healthcare debates. We're talking about very heavy regulation here. One of the points I'd like to make and I'd like you to keep in mind is that we're really going in a regulatory sense where we've never really gone before. I mean, yes, the Medicare system it's kind of like the Godzilla of regulation. But frankly, what you're looking at is going to dwarf the Medicare program in terms of simply the regulatory detail. This is going to be very, very far-reaching over the next few years. Thus far, the 2,800-page statute, 2,700, 2,800 pages, it all depends upon how you evaluate it, has produced over 10,000 pages of rules in the Federal Register. I mean, and that's just the beginning. So there's a lot more to come. Political uncertainty. I listened to Julius Hobson this morning, and I caught the end of it. This is the law of the land. There's no question about that. But neither you nor I can ever remember a time in your lifetime where a majority of states, very regionally diverse, right? This is not the South versus Washington, as it was in the old days. It's very different. It's Alaska, and Florida in court, with the majority of states challenging the federal government in court. You have never seen that in your life. You probably never will again. What this means is that there's a tremendous fault line in American life over this issue. The law is unpopular, according to all the survey research. There's never been a majority of Americans who, basically say, I really support this. However, what you have is polling showing that a majority of voters at one point or another favor repeal or oppose to the law, express opposition to the law, or favor major changes. So, as I say, the law is the law of the land, but it's certainly not settled policy. An overview on Medicare. Medicare is where the big changes are going to come that are going to affect doctors. I leave this for you, but what we're looking at is 165 provisions of the Affordable Care Act deal specifically with Medicare. The exchanges. When Diane asked me to talk to you today, she asked me to talk about the exchanges because the exchanges are going to, the state-based exchanges are going to have a big impact on the delivery of health care. First of all, the exchanges are mandates on the states. January 1st, 2014, the states shall set up a health insurance exchange. Not something that they may decide that they want to do. If the state doesn't do it, or will not do it, or cannot do it, the Secretary of HHS will intervene in the state and do it for them. The states can seek a waiver from the exchange, but under the terms of the statute, this is odd, they can't seek a waiver until 2017, 3 years into the requirement, which is bizarre. I don't know why they did that, but that's what they did. It will be a vehicle for federal subsidies, the exchange. The only kind of health plans that will be able to get federal subsidies for offsetting the cost for insurance will be health plans that are offered in the exchange. The exchange will not be simply a mechanism of state regulation, even though they're being set up by the states on behalf of the federal government, really at the order of the federal government. They're going to be a mechanism for federal regulation. So the federal rules governing insurance are going to be enforced through the state exchanges, basically. They're also going to be a mechanism for Medicaid expansion. The law requires that the state exchange will have the task of identifying people and enrolling them in Medicaid. Something you already all know is that over the next 10 years, the projected number of Americans who are to be covered under insurance under the Affordable Care Act will be approximately 32 million, according to CBO. About half of all those who are newly enrolled in insurance are going to be enrolled in Medicaid. It will also be the platform for government insurance. I want to stress this point because I think it's often, frankly, overlooked. How many of you think that that they jettisoned the public option in the healthcare law? Raise your hand. Okay, one of you, two of you. Okay, you're both wrong. Most of your colleagues are correct. Let me tell you why I say that. Yes, they did. The public option that was in the House bill is something they did not, in fact, create. They did something else, and the language came directly from the White House. What they decided to do was to give the United States Office of Personnel Management the authority, which is the agency that runs the Federal Employee Health Benefits Program. They decided to give the Office of Personnel Management, it's an agency in which I used to work, the authority to administer two national health plans, two, that would compete against private health insurance in every exchange in the country. So basically, and by the way, these two plans would be governed under rules that would be separate from the rules governing other health plans. In other words, rules governing profit margins and that kind of thing. So basically, what the federal government has done for the first time in the history of the world, basically, is to establish two national plans that are going to compete against private health insurance every place in the country. In my view, and this is my interpretation, Kathy Schoen later on, she might have a different view on this. My view is that this is in fact the public option. That's my view. That's what I think it is. Well, the exchanges are going to be a platform for that. The key regulatory functions, they're going to certify the health plans, they're going to enforce the federal quality standards. That will directly affect physicians. They will enforce the offering of the standard benefits package. That will directly affect the physicians. They'll monitor health plan premiums. In other words, the law now requires that health insurance companies must justify their premium increases in writing. This will indirectly affect physicians because if, in fact, a health insurance plan's premiums are too high, what do the health insurance plans do? Well, they cut back on reimbursement to doctors, hospitals, clinics, home health agencies, and so on. That's how they do it. You know more about this than I do. They also administer the taxpayer subsidies for those who are enrolled in the system. Now, I looked at this when I put this together in terms of the impact of physicians impacting physicians in two areas. One is their conditions of practice and also reimbursement. They're two different things, but of course they're separate and distinct. But this way, they're distinct, but they're ultimately inseparable. The exchanges under Section 1311G will basically become the vehicles for federal practice standards in the private sector. And I quoted the language. In other words, state-based exchanges will enforce federal practice standards, including quality reporting, effective case management, care coordination, chronic disease management, all that stuff. The implementation of activities to improve patient safety and reduce medical errors, the use of best clinical practices, evidence-based medicine, health information technology, all of that. Those will be federal standards, however they define them, which is something that will be defined then. But that's how the exchanges will affect the practice of medicine, or at least affect delivery, the conditions of practice. Medicare has various quality provisions. There will be a physician feedback program. There's going to be a quality of care modifier that's going to be added to the physician fee schedule. I don't know what that's going to look like, neither do you. I don't think anybody does yet. There will be a physician compare website that will be available in 2013. Something you all know about is the Physician Quality Reporting Initiative. They've preserved that and they're extending it. What they're doing in this case, under the law, it's already underway, is you get a bonus payment if you comply of 1% and subsequently 0.5%, 0.5% for the next 3 years. And in 2015, doctors must comply or they face a bonus or they face a Medicare payment cut. And that begins at 2% in 2016 and beyond, Section 3002. So that's how that's going to work, at least on paper. The conditions of reimbursement, Medicare physicians and surgeons got a 10% bonus in 2011 for Medicare. There's going to be a temporary Medicaid payment increase, as you know. Physicians taking Medicaid patients will get 100%, will have payment that equals 100% of the Medicare payment. That will be entirely financed by federal taxpayers for 2 years, 2013 and 2014. After 2014, if that level of payment is to be maintained, that is totally up to the state legislators. how they want to handle that. So that's what happens then. The SGR payment formula is retained under the law, as you all know. Julius Hobson, talked about that earlier. Right now, I mean, we're looking at a 27% Medicare payment cut if this doesn't change. I just want to mention one other thing is that, people talk about the SGR payment formula. What happens if you actually don't do anything about it? Well, if you don't do anything about it, we know what the trustees tell us. It's madness. Basically, physician payment dips to 40% of private payment in 20 years and then 25% of private insurance at the end of a 75-year period under the actuarial 75-year period. Of course, this is madness. Nothing like this is going to happen, I don't think. But nevertheless, that's how unworkable the SGR really is. The Center for Medicare and Medicaid Innovation was created to develop new payment and delivery options. There are about 20 demonstration programs that are authorized under the statute. Why this is significant is that you hear a lot of discussion about changing Medicare as we know it or ending Medicare as we know it, right? You hear that all the time in Capitol Hill. This actually does end Medicare as we know it. And a lot of people have a hard time grasping this. But as you all know, Medicare is a fee-for-service system. The whole point of this exercise is basically to transfer doctors out of fee-for-service as we know it into capitated payment or salaried health plans. The accountable care organizations, you've heard about them. That's the gain sharing programs. They're to be implemented in 2012, this year. There's the Patient-Centered Outcomes Research Institute. This is the comparative effectiveness body. It's a nonprofit, taxpayer-financed program, very unusual institution. It's financed up front by federal taxpayer financing, and then it will be financed beginning in 2013 from assessments on health insurance plans. Okay. This is a big one, as you all heard about this, the Independent Payment Advisory Board. It's a politically appointed board. There are 15 members appointed by the President, confirmed by the Senate. Their first recommendations are due in January 2015. These things go into effect. Their recommendations go into effect unless Congress enacts an alternative set of payment cuts. This is a very, very powerful board. It's subject to neither administrative review or judicial review under the law. Basically, in statute, they said the courts cannot hear objections to what they do. This is another big change from traditional Medicare. Traditional Medicare was an open-ended entitlement, basically. As physicians, you submit your claims. Your claims are paid at the end of the year. Whatever it is, the Medicare Part B trust fund, which is not really a trust fund, is nevertheless filled up by drawdowns from the Treasury to pay the bills. So whatever it was, whatever we spent on Medicare, especially in Part B and Part D, that was just all there was to it. This is changing. What they've done here is establish a cap on Medicare spending, per capita Medicare spending, for the first time in history. This was inconceivable back in the 1990s, I can tell you. The Democratic leadership, in particular in the House, were opposed to anything that looked like this and made it very clear because Gingrich at one time wanted to establish some kind of a cap, and it was defeated. It just never went anywhere. But here we have one, and it's based on inflation for the first 3 years, and then in economic growth, GDP. The recommendations of the board are exclusively focused on payment reductions. So the only thing that this board can actually do, it can't reform the Medicare program, can't change the benefit structure, can't change co-payments, can't change any of that stuff. The only thing that it can do is cut reimbursements for doctors, hospitals, and clinics, and so on. Hospitals are off limits until 2020. After that, Katie barred the door. In 2015, though, all the other Parts B, D, and C, the rural health centers, the federally qualified health centers, all of those are subject to this. I quoted here, and it's an important quote from Ezra Klein. I was quoting Peter Orszag, who was the White House budget director of OMB, who said that he says, this commission is the largest yielding of sovereignty from the Congress since the creation of the Federal Reserve. In other words, we're talking about a major delegation of legislative power to an administrative agency. That's true. I've never seen anything quite like this. As you all know, it's become very unpopular in the past, 18 months, and there has been legislation introduced in the House and the Senate to repeal the Independent Payment Advisory Board. These are the hospitals. Wow, there's a lot to say here. I'm going to go through this quickly. It's probably is less valuable to you, but in Medicare Part A, the hospital payment cuts, the reductions in payment for home health, nursing homes, hospitals, even hospice care, they're unlike anything we've ever seen before. I mean, these are big cuts. An initial 10 years for Part A, looking at cuts of $157 billion in payment cuts. Home health cuts, $39.7 billion. The reduction in hospital disproportionate share payments. In 2014, the disproportionate share payments are to equal no more than 25% of what they would have been. So you're talking about a 75% cut in dish. And there's an end to payments for physician-owned hospitals. You know all about that. It's a controversial issue. In the Affordable Care Act, when doctors created the physician-owned specialty hospitals, you're familiar with all this, they basically ended reimbursement for those. The hospitals are also under new conditions of payment. There's a hospital value-based purchasing program. In other words, the hospitals have to comply with the federal performance standards set up by HHS for pneumonia, heart attacks, hospital-acquired infections. There will be bonus payments and penalties for performance. This is very similar to what exists for physicians. There will be a hospital readmission reduction program. It's beginning in October, where they will start to penalize hospitals if they have an excessive rate of readmissions. All right, what are the expectations for the market? This is my field. This is what I know something about. I think you're going to see, under the law, an explosion of demand and constrained supply. So you're going to have an increase in coverage over the next 10 years, but the law is going to add about 32 million people to the ranks of the insured. But as I say, slightly more than half, about 16 million, are going to be covered by Medicaid. The rest are going to get taxpayer-subsidized coverage through mandatory state exchanges. You're going to see increased cost. This whole business about the cost curve being bent down, that will not happen. The Medicare actuary says, in fact, that based on the preliminary estimate, that we're going to be spending at least $311 billion more than under the previous law. Health insurance markets are going to become even more concentrated. I just want to stress this for a moment. When this was all being debated, one of the points that President Obama made in arguing for the law was that in state health insurance markets in particular, you basically did not have very much competition. There was not robust competition. I think he pointed to Alabama as one state where something like 90% of covered lives were covered by one insurance company. Well, the president was absolutely correct about that. If you look at the small group market, for example, in the state of Maryland, something like 94% of covered lives in the small group market. That's the market that covers the small businesses. It's something like 94% of covered lives are covered by two companies. Well, of course, that means that physicians are because it's not a competitive market, physicians are dealing with a duopoly, and their capacity to negotiate, reimbursements are really deeply limited when you have a non-competitive market. And of course, at the same time, for employees, you don't have employers and employees. You don't have very much choice. In any event, right now, the health insurance markets in the United States are highly concentrated. Basically, you have had mergers and acquisitions, but the figures are right now about 12 companies today cover 2/3 of all Americans. My belief or my projection based on what I know about the functioning of the health insurance markets is that the law is actually going to concentrate the health insurance markets even more. We're going to have less competition rather than more competition. And what I'm suggesting to you is that we are probably going to see the growth of very large, geographically based health insurance cartels that are going to be regulated by the federal government. Moreover, I think that the introduction of the OPM-sponsored multi-state plans that are going to compete against private health insurance all over the country are going to be instruments for that further consolidation, and I frankly think it's intentional. That's my view. I think you will have greater instability in employer-based insurance. We have an employer mandate. The employer mandate says that if an employer doesn't offer health insurance, he pays a $2,000 fine for the employee. Under certain circumstances, he would pay a $3,000 fine. My own view is that the employer mandate, coupled with the cost of a federally mandated benefit package, is probably going to cause a lot of insurers to look at this market and say, you know what, I don't need this headache anymore. These people are going into the exchanges. We're finished with this. And I think what you will get is a massive disruption of existing employer-based health insurance. I quote the McKinsey company up here. They project anywhere between 30 to 50% of employers to drop existing coverage. Now, why do you care? Well, one reason why you might is that what this will end up doing is if we have a massive disruption of employment-based health insurance, the subsidies that are required under the law to enable people to get health insurance through the exchange, the cost of those subsidies to taxpayers will explode. And that's what I think, frankly, is likely to happen. That's my view. When you're looking at the Medicaid expansion in particular, which is going to really dramatically drive up the number of people who are in Medicaid, and the growth of the senior population, which is right now 48 million, and when you get to 2030, about 80 million Americans will be enrolled in Medicare. What it really means is greater physician payment dependence. Doctors are going to be more and more getting paid, more so than they do today, from government health plans. The problem with this is that a lot of you are simply not going to do it, at least at the same level that you've done in the past. The Center for Studying Health System Change, these numbers are dated actually, 2009 numbers, but I think they're still pretty valid, and that's why I included them. They say that only 58% of physicians are going to accept all new Medicare patients, so there we are. Something that I think is particularly sad is that we'll see a continued decline in private medical practice. I think that's a disaster for the United States, but I think it's going to happen. Fewer doctors are in solo practice. I think with the ACOs and hospitals and large group practices eating up small practices, I think that's likely to continue. I think hospital consolidation will continue. That will mean a much less competitive market and will mean less capacity, just simply from the market standpoint and controlling cost. Washington has a lot of implementation challenges. That's why Julius was talking to you this morning. I don't agree with him on a lot of things, but let me just tell you, I'm talking to an audience of doctors. Tell me if I'm wrong. The data I read is that physician opposition to the law is very wide and it's very deep. And it's getting deeper. There was a poll that I did not include in this, conducted by the Doctors Company, which indicated deepening hostility to the current law among the medical profession. You have new obligations that are being imposed on the medical profession in the face of a professional shortage. For years now, for the past 3 or 4 years, we've been projecting that there are going to be shortages of physicians, particularly primary care physicians. And at the same time, while we're facing these shortages, it is federal policy to impose even more obligations on doctors for compliance and reporting requirements. And at the same time, subjecting more physicians to reimbursement under government programs. I think that's going to be a tough situation for physicians. I think hospital emergency room overcrowding is going to continue. In fact, I think it's going to get worse. And the reason why is because of the expansion of Medicaid. Medicaid expansion will guarantee you hospital emergency room overcrowding. Yes, the uninsured go to emergency rooms. You all know that. We've all seen the numbers. But the truth of the matter is a very, very large and growing portion of people who are showing up in emergency rooms for non-urgent care are people who are on Medicaid. And they are people who cannot or do not have access to a regular physician. I think with the expansion of Medicaid, hospital room overcrowding is guaranteed. Guaranteed. I think the ACO initiative, it's off to a rocky start. We're going to see the initial response by people who are involved in these kinds of things, like Mayo and Geisinger, was very hostile. They added a lot more regulation and tried to make accommodations. We'll see what the market response is to the final rules. It begins this year. IPAB is becoming the poster child for the Obamacare law. It's gaining a lot of bipartisan opposition. When you have Pete Stark of California and Paul Ryan on the same side, that kind of tells you mostly what you need to know about the political popularity of this institution. It's also being subjected to suits. The Medicare Part A cuts will guarantee access problems. That's not my opinion. That is the official judgment of the Center for Medicare and Medicaid Actuary. The actuary projects that, in fact, a lot of these institutions are not going to be able to offer the services that they're offering today at the reimbursement cuts that are based into the law. I quoted the Medicare trustees report. The Medicare trustees basically are saying the same thing. During the past 2 years, we've heard a lot about delivery reform, value-based purchasing and things of that sort. All I can say is the jury's out on that. That's what the Medicare trustees say. If you're expecting a lot of savings from this, you might get them. The fact of the matter is most adults in town who actually have to measure whether there will or will not be savings don't think there will be. And that's the judgment of the Congressional Budget Office and also the trustees. The deficit, God knows. If Congress keeps the SGR, doctors will face a 27% reduction. That's not going to happen. So nobody around here, unless you've broken diplomatic relations with reality, that you don't have to worry about that. However, if they maintain the current payment levels, CBO just came out with a report last week that says it's going to cost $316 billion over 10 years. The deficit is going to be greatly influenced by what we do with Medicare physician payment. What can I tell you? I mean, that's just a fact. And I quoted Lewin. Lewin says that if a permanent fix were adopted, you'd have $142.5 billion added to the deficit. Now, there's a way to avoid that. There's a way to avoid that. The way to avoid that is to do what a lot of them up there, frankly, don't have the guts to do, which is to make offsetting cuts in other areas of Medicare, frankly, or other areas, period. That's the only way to avoid that. The deficit is a serious issue. All right. Conclusion, I think I'm just a few sentences. This is a quantum leap in federal regulation. The delivery of care is going to be affected. Changes in the delivery of care are going to be affected by rulemaking in Medicare, Medicaid, and the exchanges. The law will change the practice of medicine and medical care generally. There will be new pressures on private practice, on doctors, hospitals, and clinics. IPAB and other institutions will further reduce physician reimbursement. And the implementation stretches over 8 years, and its success on the ground is being challenged both politically and legally, particularly among state officials. To summarize this up, I can see I'm getting looks here. To summarize this up, I would say if you want to fix what is wrong with American healthcare, the number one thing we have to fix is not you. The medical profession's delivery system is not the problem. It is the financing of healthcare. It's the financing. It's not the delivery. Yes, we do have uneven quality in the United States. You all know this. But for the most part, I mean, we do pretty good for the most part when somebody is in the system, you know, and that whether they're in Johns Hopkins or whether they're at the Baptist hospitals in Georgia, they're in pretty great shape. I mean, you know, the problem is not, it's the financing. And what's wrong with the financing? It is the way in which the insurance markets are functioning. The functioning of the insurance markets, because basically, if you look at the actual flow of dollars in the system, about 85% of those dollars that are flowing through the system are flowing through third-party payment insurance arrangements. Yet, we have a situation where patients, right, who are supposedly on the receiving end of all this, right, have absolutely no economic control at all. So what's valuable, what's not valuable, what's high quality, what's not, and all that sort of thing, they're insulated from all of that. So my response to you would be this. To fix the American healthcare economy, which is what we're talking about, it's the American healthcare economy. Number one, major premise, you must fix the health insurance markets. That's number one. Number two, this is the minor premise of the argument. That's the major premise, fix the health insurance market. The minor premise would be to fix the health insurance markets, you must fix the federal tax treatment of health insurance. You must. That's minor premise. Premise B. The conclusion will be then that if you fix the health insurance tax treatment, if you fix the tax treatment of health insurance, you will basically start to fix the healthcare economy.